Good afternoon and welcome. My name is Sue Prentice. I'm the Executive Director of the American Trauma Society, and I'm so pleased to be here once again with our partners at Pulsara and some of our folks from trauma centers in Colorado today for our webinar. We're going to talk about how technology and strong relationships equals a winning trauma patient care system. And again, we welcome you here today. And we are just, again, super pleased to be working with our partners from Pulsara. Before we get started and I turn it over to our moderator, I just want to go through a few rules of the road for our time together this afternoon. The first is all participants, so you that are attending, you're all automatically on mute. There'll be opportunities for us to take you off mute if you want to ask questions, but you all come into this on mute. Second, this webinar is recorded. So for members of the American Trauma Society, it will be located in our archives within a week. If there is someone here who's not a member of the ATS who wants access to it, we will work with Pulsara to make sure that you get a copy or have access to it. That's fine. And third is we have built in time at the end for questions and answers with our panelists as well as our moderator. So what I'm asking you to do is to either, you'll see a place where you can write your question in, or you can raise your hand. Go ahead and get into the queue. We will be paying attention to you as the event goes on when it's time for questions and answers. So again, thank you very much. And it's my honor and to turn this over to our moderator today, Kara McCoy. She is a customer success manager with Pulsara, and Kara is a former fire engineer and firefighter. So Kara, I'm going to turn it over to you.
Awesome. Thank you so much, Sue. As Sue said, my name's Kara McCoy. I'm a customer success manager here at Pulsara, and I'm glad to be here, and I'm excited to introduce today's presenters. With me, I have Sherry Steffen, Trauma Program Manager at St. Francis Hospital, and Wendy Erickson, President of the Colorado Trauma Network and Trauma Program Manager at Penrose Hospital. Both are in Colorado Springs. Colorado Springs is located in East Central Colorado in El Paso County. El Paso County is one of the fastest growing counties in Colorado with a current population of around 480,000, but the service area population is over 725,000, and it is more than 2,000 square miles. There are 5 military bases, including Army, Air Force, and Space Force, 8 hospitals, and over 30 fire and EMS agencies. And there's also an amazing view of Pikes Peak for those of you who have never been to Colorado Springs. Penrose Hospital and St. Francis Hospital are approximately 20 minutes from each other, with Penrose in the southwest portion of the city and St. Francis in the northeast. So now I'm going to let Wendy and Sherry tell you about their hospitals, starting with Wendy at Penrose.
Thanks for having me, Kara. Penrose Hospital is an ACS Level 1 facility. We're a Colorado State designated Level 2 facility. We have 300 licensed beds. We have 10 trauma surgeons, 6 trauma mid-levels. We have about 26 ED beds, and we're one of the busier EDs we've seen. And St. Francis Hospital is a Colorado State Level 3 trauma center. We do participate in TQIP. We have 317 licensed beds, and we have 5 trauma surgeons.
All right, thank you both. So to start, I would really like to go back to when you all recognized the need for something better, not just in the region, but amongst your trauma care teams as well.
Sure. So in the region, we had Pulsara about 2016. And at that time, we were just using it for stroke and STEMI. And it only went so far as pre-hospital notification to the ED charge desk. And the ED charge desk would acknowledge the alert and they would go through our inter-facility processes. We really kind of identified that there is something better when Pulsara developed the trauma team application within its program in 2021, and we were able to implement that. We introduced Pulsara through our facility at that point in time.
Awesome. All right. And could you tell me more about Pulsara as a communication system and why you all chose it over utilizing existing communication methods such as faxes, radios, and pagers?
Yeah, so prior to implementation of Pulsara, so prior to 2021 we were using a traditional radio system for communication between EMS and the hospital, traditional radio patches for all patients incoming. When we implemented Pulsara throughout our area and our region, we started using it for all EMS patches and trauma specifically. So Pulsara, the reason we chose it is that it allows for communication to the entire team rather than just the two-way communication that radios allow. And it allows the same information to go to everyone on the trauma team, including the trauma surgeon. So it helps to eliminate the telephone effect that you can get when you're patching to an ED. And it ensures that those little details aren't lost in translation. With the way that we use it, any hospital team member that is included on the patch can ask questions of EMS, and EMS can also use it to ask for direction from hospital physicians as they need it, or anything of that nature. We were also looking for a way to get rid of our pagers. We were finding that our pager system was becoming outdated and they were going to no longer service them. So we were looking for a better technology anyhow.
Awesome. All right, so I'd like to ask you a few questions about taking on this new project. So we'll start with, how did your trauma teams feel about using a new system like Pulsara? Was there much resistance or did they embrace it?
Depended on the team. Change isn't easy. The easiest part was actually reintroducing the trauma team and re-education with registration in ED. Like we said, since Pulsara was already known to our emergency department and to our registration folks with stroke and STEMI, that piece was pretty easy. The difficulty came when we tried to work through our process flow with our operations center or ops center, because they're the ones that do the page notification to the rest of the team through our traditional methods. So when we went live with our trauma notification through Pulsara, we kind of did a dual process for a little while. We did the Pulsara notifications along with the paging system. The ops team was excited because in times past they were having to manually enter the trauma surgeon on call that day, because there was no way to integrate their calendar with the paging system. So they were having to change that manually. They were also having to make sure that that was the right page. And since they didn't have to do that any longer, they were super excited. So it took a little bit of time for everybody to get on board and everybody to feel comfortable with it, but surprisingly, that didn't take that long. Very surprisingly.
All right. So then how was that change management piece of implementing the new technology?
Well, shockingly, my trauma surgeons were well on board. They immediately wanted to go with it. They were tired of making sure that their pages were right or their phones were working or the paging system was doing as it should. So they were thrilled to start and they wanted to do it right away. The difficulty came when we actually implemented it. We found a little hiccups with making sure that their iOS systems. Most of my trauma surgeons are big Apple fans, so there are occasional hiccups with iOS updates and making sure that the notifications and alerts are going through properly. So we were able to work through some of those processes, and once they were comfortable with it and able to work through that, it was okay. They weren't really sure about the benefits of it as we first started. They were hesitant. They thought, I think they were just trying to humor me and go with the flow. But thankfully, it was a few months after we started Pulsara, we actually had a case where the crew was able to send us pictures of a rather large impaled object in a patient's abdomen, and they were able to see real-time interventions that was happening on scene. And the time to the hospital was about 25 minutes, and by the time the surgeon received those photographs, and they were able to notify the OR, they were able to notify blood bank, so blood was ready, the operating room was ready, so they essentially bypassed the ED when they got to us. So it took a little bit for everybody to really understand the benefits of it, but once they realized this could be a really great communication tool, it was easy, super easy.
Yeah, awesome. All right. I know relationships can be key to a successful implementation. What role did relationships play for you all?
Well, I mean, I think we all know that if change is going to be effective, it really has to come from a team and it has to be a team effort. So having good relationships with the different members of our trauma team allowed for us to have a really honest dialogue of any concerns or problems that came up. And it also allowed us to talk about the wins that were happening when we rolled out, which gave us some traction. Had regular meetings with many different stakeholders during the rollout, including EMS, the registration teams, our operations department, the different service lines, different individual department people to discuss Pulsara, the implementation, and how things were going. And so because of those regular meetings, we were able to really quickly make needed adjustments or timely education, things like that, to provide feedback. Having those good relationships in place prior to rollout and striving for that clear communication really provided a strong foundation for our implementation. And it has allowed for our continued expansion of the system. And overall, it has really benefited our patients, our facilities, and our trauma team as well.
Yeah, thanks, Sherry. I think that's a really great transition into this next section. So now that you all have been utilizing Pulsara daily, I would like to ask more about the effects that it's had. So the first thing would be during time-sensitive emergencies and maybe even for a more routine case, how has utilizing Pulsara helped you save time?
Yeah, so as we said before, prior to this, we utilized a standard paging system. And when we went live with Pulsara for trauma specifically, we continued to use both of our systems to make sure that our transition was seamless and that we didn't miss anything. And kind of surprisingly, we found that on average, the trauma surgeon would get the Pulsara notification about 4 to 5 minutes faster than they would get the page, even though they went out at the same time. It really surprised us initially, but it was a really great surprise, right? We were really excited about that. And another time-saving thing that we have found is that we are able to pre-register patients. So registration team members are included as part of our trauma team, but also for our facilities as part of every EMS patch. And they are able to pre-register those patients because we have worked with EMS to ensure that we get proper patient identification through Pulsara. So they're able to get a confirmed identification prior to patient arrival, and they pre-register that patient. So for critical patients, for trauma teams specifically, the patient is in our electronic health record prior to arrival. And if they've ever had a stay with us before, we may have past medical history or things like that, that we're able to review prior to the patient getting there. So that can help speed things up. And then we also are able to plan orders and even enter some orders prior to patient arrival because they're pre-registered, which then when they arrive, the provider just hits the button and the orders go through rather than having to find all the orders after registration. So I think that that helps save quite a bit of time when you're talking about an emergent case. That has been a really big win for us.
It helps too because it limits the amount of John Doe patients that we have. It also helps when we have things like emergent blood transfusions, particularly massive transfusions. If we can pre-register somebody and not have them as a John Doe patient, because that can cause a whole huge mess if you're massively transfusing people and then need to continue it on into their hospital stay. So if we have that record available, it just creates a lot of ease down the line.
Yeah, great point. You all have mentioned your field crews quite a bit. So would you say that rolling out Pulsara to your trauma teams has helped build and strengthen your relationships with fire and EMS agencies? Does this make them more of an integral part of the patient care continuum?
Yeah, I think initially the change is hard, right? Change is hard for anyone. And when we told the EMS crews that they were going to then patch via Pulsara, it's a whole different workflow and it took some time. But now that we have it established, we have hospital-based EMS coordinators who are involved in each of the individual cases on Pulsara, and they're able to utilize that to provide timely feedback or education to the EMS crews, based on the patch that we receive. And because the whole trauma team is receiving the same information and they're able to speak to each other, the trauma surgeons are actually able to provide feedback directly to EMS as well, which is a huge win. One of the nice things that we have found is that all of the information is included. So if fire is first on scene, they can start the patient channel, enter the information that they have, and then when the transporting unit arrives, they then transfer care over and they continue in that same patient channel. So all of the caregivers from start to finish get all of the same information and they see the entire case. Whereas if you patch in, you're getting just the snippet, the last set of vitals or things like that. Really one of the big things that has helped build and strengthen the relationship is the ability to anticipate and prepare for that patient, right? We want to do what's best for our patient, and EMS wants to take their patients to a hospital that's ready to go and is prepared. So when we anticipate needs based on what information EMS has provided, and we activate OR, activate IR, EMS knows that they have been heard and that the information that they provided to us is valuable. Feeling valuable will always help strengthen relationships.
As is the patient feedback too.
Yeah.
When the case is done, we can share your eye, or the trauma surgeon can enter feedback to that case, and we can say, hey, great save, or we can get in touch with the crew a little better because we can identify folks who are on it. So if we have questions or concerns with our processes, we can address those too.
Yeah, I know that when I was in the field and we had patients sending off to the hospital, once we handed them off to EMS, I never found out what happened to that patient again. And so I think it's really powerful for crews all the way down to the first responders being on Pulsara, the fact that they can even get feedback. I think that's great. All right. So how has this benefited the trauma program based on how you all specifically use it?
Sure. Well, not only that communication with EMS, because we should be giving feedback to our crews and letting them know how they did or what could have been done better, or hey, thanks for bringing these patients to us. But some of the large benefits to our trauma program have been because it's a cloud-based platform, we can immediately receive those recordings if the crew decides to record their patch, or we can identify through their narrative if the patient met our team activation protocols, or through their photographs or through their interventions that they've documented, we can identify any care issues that we may find. Just from an EMS perspective, from a trauma program perspective, it's kind of a tattletale thing, because I can see when the trauma surgeon acknowledges the trauma page, right? So the alert goes through and there's a little green check mark when he or she acknowledges the alert. So there's no more of this, well, my pager doesn't work, I don't get signal in this area. I slept through it, the battery doesn't work, that sort of thing. So I can have a conversation about, the alert went through, why did it take you 20 minutes to acknowledge it? Which doesn't ever happen because it's a pretty apparent alert on their cell phones. And thankfully, because of that, and they've stopped carrying pagers, it's on their person all the time, and it's not a different device that they have to switch off with somebody to do. So through all of that, and we can timeline the entire team that is on that activation, so we can see who was on the case, who acknowledged it, sorry, and we can give direct feedback to anyone on that case, or we can do a little more PI process as to the timeline of things, because we as trauma, we armchair quarterback, and we can timeline things all the time. Sometimes documentation doesn't quite match up and we don't have real-time things. So we spend a lot of time playing detective on how things went, and Pulsara certainly helps with that.
The other kind of benefit for our program is we can run reports out of Pulsara. So, radio patches, unless I'm going to individually drill down each of those radio patches, I'm not going to get data that is useful in that sense without running reports from our electronic health record, which may or may not be accurate for what EMS has. So the fact that we can run reports out of Pulsara and look at how many teams came in, or how many trauma patients in general came in via EMS this month, how many we activated via POV this month, as a quick look, and look at data over time, has been really helpful for the program.
Nice. Yeah, going back to the radio patch part, I always tell EMS, you could give the world's best radio report, but traditionally only one person is hearing that. And then it's their job to play that game of telephone with downstream teams. So I do love the fact that not only does everyone get to hear it, but you all on the back end get to go back, listen to it. I think it can be a great learning curve too. Hey, this is the information you put in Pulsara when you alerted the hospital, but we could have used this one more key piece to have more of the information we need to make decisions in the hospital.
That's been super helpful for our ED charge teams to be able to make those decisions as well. So we can go back and say, we used to have a guideline that standardized EMS patch reports, and frankly, it was ridiculous. But we used to try to mandate what they would tell us as kind of a script, and Pulsara certainly helps with that. And that feedback can be like, hey, do you have, or if the ED charge nurse has questions, they can immediately type it in versus trying to get a hold of them on the radio.
Yeah, good point. All right. Well, we're going to move on to some wins and future state items. So since implementing Pulsara, what are some of the biggest benefits and wins for patient care? And did you encounter any unforeseen benefits?
Yeah, I think we've seen a lot more benefits than we anticipated. But really, we've mentioned this, but I think one of the biggest benefits is the ability to better plan for a specific trauma patient coming in prior to their arrival. Whether that means we activated IR, OR quickly, called a specific specialty consult service prior to the patient arrival because we got a picture of this person's face that's not in the right spot, or whatever the case may be. We're able to utilize that information to plan and affect the patient care. We all want the best care for our patients, right? We hopefully all want the best care for our patients. So
That's why we do it.
Yeah, everyone from pre-hospital to hospital and beyond wants the best outcome. And so anything that we can do to improve the chances of that patient having a good outcome is a win. Probably the biggest win is the time savings piece that we have found, partially from the things we just talked about with being able to pre-plan and save time in that front, but really faster notification of a trauma surgeon is huge. 5 minutes feels, it's not, it's only a few minutes, it's not a big deal, but really in severe trauma, minutes matter and can alter a patient's outcome. And knowing that my trauma surgeon is getting notified, especially as a level 3 where my surgeon is not in-house, they're up to 20 minutes away, that 5 minutes can be a big difference. They're getting notified 5 minutes faster. through Pulsara than they were through pagers. And so that's 5 minutes faster that they will get to the bedside, 5 minutes faster that they may be able to take this patient to definitive care. And then the ability to pre-register a patient, the ability to look at his health history and see if, anything that will affect the patient care this time is in their past. Some of these trauma patients come in altered, and without knowing those things, I think you can sometimes have errors and problems. So knowing that is really helpful.
Yeah. All right. So how has it grown? Have you been able to get any other teams on board with Pulsara since trauma rolled out?
Yeah, because everybody wants to be the cool kids on the block, right? It's the new toy. So when we first started with our Pulsara implementation for trauma, our aim was to try to make this change as easy as possible. So like I said, prior to Pulsara, the patch or the Pulsara alert would come to the ED charge. The ED charge would then acknowledge the alert, ask the questions on Pulsara, do his or her thing. Then they would pick up the phone and call our operations center, and they would tell the same thing to our operations center, spend a few minutes doing that, then having to call and notify people. Ops would then page out the team. It was a whole kind of onerous process. And what we didn't want to do was to add to that. We didn't want to make that more cumbersome than it already is. So when we implemented it, then we knew that the more people we could get on the app, the less notification would be needed by our ops team, and the more timely those notifications would go to those team members. So it was kind of fun to see it was probably about 60 days after we started, CT was like, hey, how come the trauma surgeons know about this before I do? And they came on board, and now they're alerted as the trauma activations are alerted. And since we've added CT, we've added blood bank and now respiratory therapy, and we're working on the OR team to make sure that they get those notifications as well. Because again, everybody can see what's going down instead of the, 35-year-old male gunshot wound. Well, gunshot wound to where and for how long and what's happening, that sort of thing. It's really been pretty infectious, which I kind of love, because I'm not competitive or anything. Other departments and service lines have noted really how easy it is, and how awesome the communication has been, not just to EMS, but to the other teams. It's really kind of funny that the stroke team was able to get their neurologists on board by kind of teasing them a little bit. The trauma surgeons can do it. You can do it. So it's true. So it's been really exciting to see how it's come kind of full circle into the house.
Our cardiologists were on board when we first went live in 2016, because they could see an EKG, but it didn't work in the way that they wanted, and they kind of backed off and said, no go, we're not doing this anymore. And since we've gone live, cardiology's back on board as well. And in the sense of their flow, they're able to see the EKG, and all of the EMS records, but they're able to look at that EKG and plan for cath lab and what they're going to need to do before the patient rolls through the door. Before they were waiting for the patient to roll in so they could look at that EKG and go from there. So it's been really helpful, and it's growing a lot. It's nice that we were kind of the pushers, because again, we're not competitive, but we were first and we won. So
we'll take it.
Yeah.
Absolutely. That's so true. All right. Yeah, I spoke with the cardiologist recently too, and they're really enjoying it. So good on you for, relighting that flame. And I think it's really helpful too that Pulsara is monitor agnostic. So, y'all have a lot of agencies transporting. So I think it's nice that they can use one platform to transmit that EKG to any team that would need it, without having to. If you're going to transport to this hospital, you can only get the EKG across if it's this type of monitor. I think that's really helped as well.
Well, and I have to add too, since we've implemented it, Pulsara has really grown too, because in 2016, at the time, the platform hadn't matured enough to where if fire started the case, that device that it was started on would have to travel with the patient in order to keep care continuous. And since we've been able to go, kudos to your team at Pulsara for really listening and taking on some of those challenges and making it so much easier to use.
Thank you. Well, you all provide great feedback. You're using it so much every day that our dev team is always happy to take feedback from the Colorado Springs region and do what they can to make things better every day.
I'm sure they're tired of hearing from us, really.
Never. All right, cool. So what are some of the things you're doing now to continue to manage and maintain that Pulsara utilization?
Yeah, well, it won't always be the shiny new toy, right? But the longer it's the shiny new toy, the better, because it keeps it fresh in people's minds. But different things are coming out. So recently we started using calendar integration, well, I guess about a year ago, which essentially links Pulsara to our providers' call schedules. So for trauma, they have their call schedule in our call scheduling system, and Pulsara links to that, and it automatically puts the appropriate trauma surgeon on call when their call starts. So at 7 a.m., they go on call, and Pulsara does it for them. They really love not having to go in and put themselves on call, and they still have the ability, if I'm stepping out for a meeting, so and so can go on call instead, and they still have the ability to change it. But the fact that they don't have to manually enter their schedules and that it will just pull from their call schedule is a big win for them. And then we started even more recently using Pulsara for our hospital availability in our area. So prior to this, the system that we used allowed us to enter our availability. It's a statewide system that we use here in Colorado, and it was visible to anyone who had access, and that usually meant dispatch and some random EMS chief who happened to remember their password, but not your everyday unit, right? So not your transporting units. They didn't have access to our system to be able to see our hospital availability. So it either had to be communicated through dispatch, or EMS would patch in with a patient, and at the end of their patch, we would go, actually, we're on psych and alcohol divert. Do you think you could, go somewhere else? That'd be great. And then they're calling somewhere else and patching again and rerouting, and it's just really kind of a complex issue. So now we're utilizing the hospital availability function in Pulsara. So when EMS selects St. Francis Hospital as their destination, it pops up what we're available. So it will say open, or any advisories that we have, or any divert status that we have, so that they can immediately see that the facility that they have chosen can or cannot accept that patient at this time. And so just being able to see that has really helped our relationship with EMS, one, because it's frustrating when you patch in and then we tell you, oh, no, that's not a good plan, then it just creates more work for you. So it helps those relationships, and it has also helped save time.
Yeah, and I love the way you all are using it down there, because with the feature, it's just an empty open box that you can type anything into. So you all have those nice templates you can copy and paste over that show any type of divert or redirect. And I think it's super helpful for EMS to be able to see that the second they go to choose the destination, instead of previous process where you would all have to communicate back and forth. That can be kind of dangerous, so to speak, if they're dealing with a critical patient. They send the alert and then they don't make an effort to check back in with you all because their hands are full. I just think it's really powerful for them to see that, especially for critical patients, right when they go to select the destination. So
yeah, right. And we worked hard as a region. We have multiple systems in our region, multiple hospital systems, and we worked really hard to make sure that we were all on the same page, because it wouldn't be fair to our many EMS agencies to have something different show up when they select my hospital versus a hospital across town. So we worked to create those templates to match what we show as open or closed. And so it's very structured, and it's the same no matter where they choose in our city, despite hospital system.
yeah,
well, and from a trauma standpoint, we're able to ensure that the crews, if their patient has an injury of any kind, they categorize that patient as a trauma. And we as hospital systems in the city, because as Sherry mentioned, there are a couple, we are not mandating the crews to try to remember what my activation criteria is versus what Sherry's is, what the place across town is, that sort of thing. They just put all the information in their patch. It's up to the ED charge nurse, and the ED charge nurse can reach it out from them. They just need to pick a destination to get to us, provided with the guidelines, of course.
Yeah, and so speaking about like how you all are using it on a regional level, I think one of the very successful things that we've implemented is that regional communications committee meeting where service line leaders from the hospital and fire and EMS leadership can all come together at a regular cadence and talk about any new features you all want to roll out, how to improve current process. I mean, I think having that regional communication has been just huge for keeping everyone on track.
Really important because we can't make a unilateral decision. We can't decide something's going to be different for our facility when it comes to EMS.
Mm-hmm.
We can decide whatever we want after that patient gets to our doors, but the regional communications meetings have been really helpful with making sure that all of our hospital systems and EMS, including our EMS medical director and our crews, are on the same page, and that it's doable for everyone.
And it's not just Wendy dreaming things up, because I could do that all day long. Yeah.
There you go. All right, awesome. Next question here. Me think I'm missing my control here. Just one second. All right, here we go. Okay, so what does the future look like for you all? Are there any plans to expand your trauma program initiatives or even your use cases for Pulsara?
So there's a lot. There's a lot happening, not just with Penrose and with St. Francis, but with the region and with the state too. So Penrose St. Francis or Common Spirit has recently built St. Francis Interquest, and that's a brand new hospital on the northeast side of town. They are not currently a designated trauma center, but they built it as the hospital of the future. So all of the nurses are carrying iPhones, there are tablets and technology throughout the hospital that really help communicate with the EHR and help communicate with the care team. It's really a fascinating walk through what probably should be happening in all facilities nationwide, but it comes down to funding, right? So thankfully, we were able to push this through at St. Francis Interquest. So as that technology is adopted through the house, we are able to expand Pulsara applications through the house as well. So as we've trialed some of that at Interquest, it's hopefully going to come down to St. Francis Hospital and to Penrose, so that we're going to be able to include more teams and more staff on these notifications. Hospital availability has been huge in the state of Colorado. There's been a large conversation about adopting Pulsara as our notification system. During COVID, there was a huge push for bed availability, and our current system worked well, particularly with nursing home beds or those acute managed beds. So there's some conversations at the state about how all of that would work. But most exciting for Pulsara and for us as a trauma center and for us as a region has been the MCI module with Pulsara. So field crews are able to use their start triage or use their field triage in a mass casualty event or mass casualty incident. And they're able to immediately categorize that patient as red, yellow, or green per their local protocols. And that notification or those colors are then notified to a larger HQ and notified to the hospital as well. So at Penrose Hospital, I can open Pulsara HQ and I can see that we're getting 10 reds and a couple of yellows and a few greens, and I can help manage that. But I can see them before they arrive to the hospital. And on a regional scale, it gives the scene commanders much more of a better idea of where those patients are going and how many there are. And huge kudos to our regional team and to one of our local fire chiefs for kind of pulling all of that together. That was a huge yeoman's amount of work, and God bless Chief Pearson. He's really done an amazing job in trying pulling us all together and how we do that. That was really born out of we were unfortunate to have the Club Q shooting here last November. And with any MCI, right, communication is a challenge. Where are patients going? How many patients are there? How do we know we have all of the casualties cataloged on scene versus are we able to triage to the appropriate center? With that came the wristband and the patient tracking technology that's coming as well. So the idea with the wristbands are that they're a blue wristband with a barcode. That barcode is specific to that patient. The crew then scans that barcode, assigns it to that case in Pulsara, and then wherever that patient may go, either through the city or, God forbid, it was a huge regional event and we had to send them to Denver. They could scan if the receiving facility had Pulsara, they could scan, and that way we could track to see where all the patients go and we have an idea of how many and where they're headed.
And the other perk with that is that, you know, a huge majority of your patients are going to come in POV, and those patients are not always well tracked in your MCI. And so this module allows for the hospital to band and scan and add those patients to the MCI incident. And it allows everyone, your scene commanders, your hospital administration, your incident command, to see
your regional
total number of patients that each facility has. A lot of those patients get lost in the translation when you're talking about MCIs and their arrival via POV. And so this really helps organize and keep things very clearly communicated.
It's much better allocation of resources and availability through that. The same token with that patient, those patient bands and all of that patient tracking and availability is Colorado. We are blessed to be fairly progressive. We have very progressive EMS medical directors. And they are working on various things like field thoracotomies. If the patient's in extremis, nobody out there in trauma will freak out. Believe me, the patient's got to be in pretty dire straits for them to actually do a thoracotomy in the field. But per our protocols, but we're also working to work with the San Antonio RETAC or the STRAC to adopt the whole blood initiative here in Colorado Springs, and particularly in our urban region. So our hope is that we can develop some way along the ideas of this wristband tracking to help implement some of the whole blood tracking as well, so that we can make sure that not only are the appropriate patients receiving those units of whole blood, but we can track those units to lessen wastage, ensure appropriate delivery of those units, and that sort of thing as well. So there's a lot on the horizon and there's a lot up and coming, and it's just really exciting to see where technology can take us.
Yeah, awesome. Thank you for sharing all of that. All right, and our last slide here. Oh yeah, I forgot that we had this bonus slide. So you were talking about the MCI functionality. That looks like our drill in Monument, possibly, that Chief Pearson put on for the El Paso County agencies. So there's a good view there.
HQ was jealous of this because I could see on my HQ what was coming, and they're like, well, how do you know what's coming in? And I'm like, because I can see it.
Yeah.
So they've adapted that into their processes.
Yeah, there's a nice view of that mobile command view there too. All right. Okay, so just final question here for you all before we go into Q&A, and that is, what advice would you give to other trauma program managers or hospital leaders who are interested in utilizing a system like this in their area?
I think, as with any change management, setting that solid foundation with your really strong relationships and ensuring open communication is really key. Make sure that you have your stakeholders present from the beginning so that so that this is built and implemented in a way that will work for your region and your facility. You really have to have EMS and hospital buy-in. I mean, I guess it would be possible to use this just in your facility, and it is a great communication tool, but having EMS buy-in really puts the icing on it. So it is important. Identify your champions in your different areas so that they will support the implementation and can really get the ball rolling. And just kind of remember that there are a lot of pieces to this puzzle. You don't have to implement all of the pieces at one time. You can start small and build your way up once you kind of work those kinks out and figure out what pieces you want to use for your area. We've been using this for a long time at this point, and we're still growing. I mean, Wendy just talked about all the new things that we're coming up with, and then the new things that we're using. We continue to improve in the way that we use this tool on a day-to-day basis, and for our large-scale incidents. So I'm really excited to see what will come.
Yeah, I would say too, it helps to process flow out the communication pathways for your teams, and how this may benefit your teams and your processes. Involvement of administration early, and administration buy-in is key as well, to have that champion. To sometimes, Sherry said, change isn't easy, and sometimes we need a heavy weight behind some decisions sometimes. Thankfully, we didn't really have too much of that in our systems, but I can see how if administration isn't in full support, it can be a bit of a challenge for some of your less change-minded teams.
Yeah, that's a great point. And also, Sherry, you made a great point about like you don't have to change everything at once. You can take off bite-sized chunks with a project like this. You can start with EMS to ED and iron out your processes there, and then loop in, you know, your next downstream team for your next service line. So there is no right or wrong way, I don't think, to pick how you attack your project. It's just, you know, what works for your specific hospital or region. So it's a good point there.
And don't forget to develop those relationships in your region, because you're going to need those.
Okay, so now I'm going to hand things back off to Sue for our Q&A. Thank you both so much for answering the questions thus far, and we'll see if we have anything else.
Great, we do have some questions, so hang on a second. I'm just going to shut the main screen off so they can just see the team here. Okay, great. So thank you, everyone. This has been a great conversation. We do have a number of questions, but one of the first questions I want to ask is for Wendy or Sherry. Can you think of a particular case from, beginning, in the field to the operating room that, you could share that was, really highlights the systemic advantages of having one channel of communication?
Yeah, that would be our lady with the large impalement in her abdomen. She was a high velocity mechanism with a large object in her belly. So EMS crews were able to start documenting vital signs on scene. They were able to take pictures of the wound and to take pictures of the scene, and to try to give trauma surgeons a really good idea of what was happening and what may be needed. So through that communication, we at the hospital were able to activate our full team, of course, notify trauma surgeons right away, and they were already privy to all of that information through the platform. They then, at that time, we didn't have blood bank and CT on board, or OR yet. We still are working on them. But they were able to make the appropriate phone calls. So not only did we have blood ready and waiting, because again, we're not at whole blood or blood on scene yet. So we were able to start blood as soon as she was rolling through the door in the ED. And I think her ED time was probably less than 20 minutes. It was probably less than 10 minutes, I think, if I recall. So they started blood and they took her right to the operating room. And through all of that communication, the surgeons were able to talk to IR if she needed embolization, to make sure that if we needed the hybrid suite, they were available. With the location of that object, there may have been associated vascular. They had vascular surgeon there. They were ready and waiting. So it really went as if you could plan out a trauma team and a trauma activation, it really went as seamless as you could possibly have one.
That's a great example of, you know, how this, from beginning through to the operating room, how this system works and connects folks in a seamless way. Thank you very much. So there's some more questions that we have. One of which I wanted to ask is about how does this all work with reporting? So when you're thinking about data, timestamps, benchmarks, does this create more work or does it automate the process?
Sometimes it actually automates the process because it's easier to find and it's more real-time documentation versus their EMS trip sheet. Where the difficulty lies is that Pulsara is not an official documentation tool, it's a communication tool. So crews are still required to use their EMRs or to their run sheets. So sometimes we don't look immediately in Pulsara. We'll look at their run sheet and 1 and 1 equals blue, and we can't figure out what's happening in that case. So we go back to the Pulsara line of communication, and it allows us to be able to see a little bit more timely timeline, as well as we can immediately communicate with that crew if things aren't adding up. So it helps with PI in that way. So if we have to go fact finding, for sure. The reports actually allow us to see what criterion our trauma activations are using, or how quickly our EDs are using it, or how much they're using it. So that can use as a PI tool to help with your over and under activation as well.
Yeah, in terms of each individual patient, I think it helps substantially with PI. Of course, we don't typically have trauma surgeon delays, but if you have a trauma surgeon delay, before you were calling your operations center and saying, okay, what time did the ED call you? And then you were finding the radio patch and you were trying to get a timestamp from that. You were listening to it. And then, so you're trying to find where the delay happened. Was it between patch and the ED calling? Was it between ED calling and getting the page out? Was it my surgeon? Where did this delay happen? Whereas in Pulsara, it gets, I can see a nice little log that says at, 1802, EMS sent it to the hospital. At 1803, the ED hit activate, and I can see which nurse did that. At 1804, trauma surgeon A viewed the chart. And so you get a really nice timeline. And so I think it really saves time in that sense. But then the overall data, I don't think it adds work because you don't have to use it, but it does give you another tool.
That's great. Thanks, Wendy and Sherry. That's perfect. Thank you so much. So I have Aaron from New England, Norwalk, Connecticut. Aaron, I'm from Lebanon, New Hampshire, not too far up the road. He has a question. Have you had any issues with pre-registration affecting door-to-doctor times? If so, how did you address them?
We have not. If the crew is unable to provide ID identification and they're not able to pre-register, we just revert back to our DOE protocols. So we're able to make them a John or Jane Doe per our processes, and then it just works that way. It does. The only delays that may be perceived then are the difficulty in making sure that that patient is banded then as that DOE, and that those orders are through that way. And sometimes our biggest hangups with the DOE process in of itself is the blood transfusion piece, because once we re-identify that patient, then they've got to be retyped and crossed. So it's easier if they pre-register them, but if they don't, it's not mandated.
Okay.
And there are multiple ways. We allow pre-registration with either a picture of the photo ID, which is the most common. And now actually Pulsara allows for them to physically scan the back of the ID, and it inputs all the information for them, so they don't have to type in name.
Digital IDs, maybe they're great.
So that piece helps. And then, or if they just have a name, they can use name and last four of social, and we allow that as a positive identification in our system. So there's a couple ways we can use pre-registration, but I haven't noticed any place.
Okay, great. Great examples. Thanks for the question, Erin. I have a question from Ruth. And hey, Ruth, I'm not sure where you're from, but thank you for tuning in today. And Ruth wants to know, and I think you've addressed this somewhat, but let's just get back to it. Are you able to link Pulsara PCR to Epic Trauma Flow Sheet and Epic Flow Sheet Trauma Navigator and times and procedures?
Carrie, you want to handle that one?
Yeah, so Pulsara has what's called a public API, meaning we are willing and able to integrate with anyone willing and able to integrate with us. So we do have some working EPCR and EHR integrations with both EMS and the hospital. So ultimately, it's just up to those agencies or facilities if they want to consume the integration and what they decide to pull over from that.
Okay, great. Wendy and Sherry, any comments on that? All good? Thumbs up? Okay.
Yeah, we're working on it.
Yeah, we're trying.
We haven't gotten there yet for our PI processes, so we can't use it like in our trauma registry because it's not out of the EHR unless we print that record and scan it into the EHR so we can find it for data validation purposes. But we're working on it. We're getting there.
That's great. I'm sure that will, be key for the trauma registrars. We're such an important link, obviously, in our trauma systems. So I have a question from Kathy from Pennsylvania. Hey, Kathy, thank you for joining us today. Her question has to do with, thinking of systems of care and understanding that interfacility transfers are, in trauma care are part of that system. Do you have any experience, either Wendy or Sherry or Kara, with using Pulsara to locate and facilitate the availability of a unit to do an interfacility transfer? Oh, Wendy and Sherry look really excited.
Well, because I transfer quite a bit to Wendy. So this is kind of up and coming. We are just getting started with banding every patient in our region by EMS. And so once every patient is banded, the ability to then just go into Pulsara and transfer the care over to another facility is really seamless. And so that is an exciting up and coming feature for us. Because we are going to be able to utilize that to continue the care going forward.
And I would say that it's very common for a hospital system to have their own transfer center. And so there is a need to still communicate with your transfer center, which Pulsara can fit very nicely into some transfer center processes. Other folks maybe just like, let's say it's a STEMI transfer and they just want to use Pulsara to get the EKG to the cardiologist who's going to take care of this patient. That's also very easy to do and then follow your current process. If your transfer center doesn't see a need or desire to be involved in Pulsara, that still doesn't stop us from getting information from one place to the other. So it's pretty seamless.
Okay, great. Thank you so much. And so I have some more questions, but procedurally, I put the screen back up because it has the email addresses for Sherry, for Wendy, and for Kara. And I also put in the chat box mine because somebody had a question about they have two coworkers together and they're looking to get a certificate for the program. Can they attend together? Absolutely fine. Look, Wendy and Sherry are sitting together. We're good with that. So just email me directly and I'll take care of that. And from behind the scenes, the Wizard of Oz, Nathan, if you're able to just type these into the chat box before we close out, that's just one more step, folks. Another place folks can cut and paste your email addresses. All right, I have a question for you. This comes from Chris from Delaware. how complex is this? Is this easy to set up and adopt, or is there a big learning curve? And I know that you, this was part of the early discussion in bringing the program on board, and I wish I caught this question earlier. I popped it up to the top, but do you want to touch on that? And what struck me during that part of the discussion, I was thinking about how, when I worked in a level 2, how would I say maybe drill folks once I got the, I got them used to, the idea and making the change. How would I move them through testing out the process? Go ahead.
Sure. Well, it helped to have those regional relationships because we didn't want to build it. I mean, thankfully, it was already established in the region, and we already had a pretty good idea of its functionality before trauma really became involved. So introducing our trauma surgeons, well, my trauma surgeons to it, they were very excited they didn't have to carry around a pager. They were very excited they didn't come across a 5-digit page across their phones because some of their phone carriers would block that automatically as spam. So there was a lot of testing involved, and there was a lot of identification of technology needs beforehand. For instance, we needed to know when we implemented it in 2016 for stroke and STEMI, we needed to make sure that registration had iPads and everybody had the appropriate technology and appropriate ability to interact with the application. And that was probably the biggest challenge versus getting people on board to the communication process. I'm sure you're aware that anybody in the trauma team or anybody in the hospital is more than willing to have an easier way of communicating with their team. So that was really a win for us. Once we were able to have Kara and Kate demonstrate it for us, it was really kind of a, yep, we're doing it. We just needed to make sure that we had the appropriate technology and Wi-Fi capabilities in-house to make sure that those messages went out appropriately.
Yeah, I mean, I think if you're talking about regional implementation and starting this from scratch,
that's a bigger piece to chew.
Yeah, the biggest fight you're going to have to take is EMS, and that's a lot of people depending on your region. It's a lot of different agencies depending on your region, and so getting EMS on board is kind of step one, and that's probably the biggest thing that you have to do. Once it gets to the hospital side, it's a much easier process because, well, so long as you have an administrator that's on board, it is what it is, and let's do it. So really, I think getting EMS set up was probably the biggest step. And then once that was done, it was a much more kind of an easy flow.
Right.
That doesn't answer all your questions. It was a lot more complicated than that step by step, but yeah, it wasn't that bad.
Yeah, and I'll just kind of add to that just for folks who don't know. Pulsara is HIPAA compliant, cloud-based. We operate on iOS and Android enabled devices. So we as a company, we don't provide any hardware. We kind of leave that up to the agency and the facility. What do you want to use? Do you want to use an iPad? Do you want to use an iPhone? Do you want to use a desktop? We definitely have options. And the only requirement, like Wendy said, is connectivity. So whether that be cellular or wireless, that is a requirement. So.
If we do have, we do have some very rural areas in our region that don't have connectivity, and EMS is able to start that patient channel and enter all the information. And once they reach an area of connectivity, it will send it on. So,
Sherry, and actually all of you, thank you for sharing those points, because Kara, you touched on what would have been, because we're starting to run over my final question that had to do with the different ways you could connect. And so you talked about text, Android, I'm sure iPhone, that there's video chat capabilities. And, speaking in the voice of risk managers, these are HIPAA compliant. So that's always good to point out. And Sherry and Wendy, the point about EMS in, there's plenty of rural coverage in this nation. And, we're always looking for new ways. It's just not as easy to pick up a cell phone or plug into Wi-Fi anywhere. So the fact that, that is addressed and thought about, like you can get your message up and going, and the minute you hit it, it will automatically, start the process. I think that that's a real advantage, because, it's important in the more urban, suburban settings, certainly, but the further out you are, that that, not just that heads up, but more information. It just smooths the system for that rural patient when they hit the front door. So for those of you that are listening today and you're looking for the email addresses, they're up on the screen, but also thank you to Nathan for putting them in our chat box. And again, mine is in there, so feel free if there's something that you need to send me a message. I would be happy to help you. On behalf of the American Trauma Society, working to save lives, improve care, and empower survivors, I want to thank our partners at Pulsara. I want to thank Kara, the great moderator today, and Wendy and Sherry, our trauma program managers, working in the same system, but in 2 different facilities, implementing a system that works through the continuum of care for you, sharing your experience. This has been a great conversation, and as always, I look forward to more. See you all out there.
Thank you.
Thank you.
Thank you.